my dear friends. So as a part of the continuation of the endocrinology series, in this session I will be discussing the very important topic, that is the Conn syndrome. Now first let me tell you what exactly you mean by this word, the Conn syndrome. Conn syndrome is a clinical condition which is characterized by increase in the aldosterone levels. So before going on to the discussion of the Conn syndrome, let me just explain you the basic physiology of aldosterone. So if you take the site of production of aldosterone, it is produced from zona glomerulosa of adrenal cortex. Right, it is produced from zona glomerulosa of the adrenal cortex. Now adrenal cortex, it has three layers: zona glomerulosa, zona fasciculata and zona reticularis. Zona glomerulosa, it will produce aldosterone. Zona fasciculata will produce the steroids, that is corticosteroids, and zona reticularis, it will produce the weak sex hormones, that is dihydroxyepiandrosterone acetate or the androstenedione. So the site of production of aldosterone is the zona glomerulosa of adrenal cortex. Now, if you take the site of action of the aldosterone, site of action of the aldosterone is on the distal convoluted tubule, right? And the cells on which this particular aldosterone will act is the principal cells. Right, the cells on which the aldosterone will act is the principal cells. Next, you take the channels. On the principal cells, we have the channels, and the name of these particular channels are epithelial sodium channels. Right, the name of these channels are epithelial sodium channels. So your aldosterone, it will act on the epithelial sodium channels of the principal cells which are present within the distal convoluted tubule. Now, what will be the physiological action of aldosterone? So if you take the physiological action of the aldosterone, it causes sodium and water retention, number 2, it causes potassium excretion, number 3, it causes the H plus ion excretion. That is what is the physiological action of the aldosterone. Now, very important point is the regulation of aldosterone secretion. If you see the regulation of aldosterone secretion, it is completely dependent on the RAS mechanism. Right? It is completely dependent on the renin-angiotensin-aldosterone system. Whereas you take the other adrenal cortical hormones like your corticosteroids and as well as the weak sex hormones, they are completely under the control of your adrenocorticotropic hormone, which is coming from anterior pituitary. But for aldosterone secretion, it is completely dependent on the renin-angiotensin-aldosterone system. Let me explain you about this particular RAS mechanism. So whenever there is decrease in the blood pressure of the individual, what is the main function of aldosterone? We have discussed maintenance of the blood pressure. That is the important function of your aldosterone. So whenever there is, for suppose due to any condition, if there is fall in the blood pressure of the individual, what will happen to your glomerular filtration rate? The glomerular filtration rate will be reduced, right? And once this particular glomerular filtration rate is reduced, there will be release of renin. There will be release of renin from JG cells. right? There will be release of renin from JG cells, and this particular renin will act on angiotensinogen, right? Will act on angiotensinogen. Now this angiotensinogen is converted into angiotensin 1. Now this particular angiotensin 1, in the presence of enzyme angiotensin converting enzyme, it is converted into angiotensin 2, right? It is converted to angiotensin 2. Now this particular angiotensin 2 will act on zona glomerulosa, right? Will act on zona glomerulosa to produce the aldosterone, right? To produce the aldosterone. So that is the mechanism of the RAS, and that is the regulation of the aldosterone by your RAS mechanism. So this is about the basic physiology of aldosterone, action of the aldosterone, and regulation of the aldosterone. Now let me discuss in detail about the Conn syndrome and as well as the hyperaldosteronism. What did I tell you about the Conn syndrome? It is a clinical condition which is characterized by hyperaldosteronism. Now let me discuss the etiology of Conn's. So if you see this important question, what is the most common cause of the Conn syndrome? The options are adrenal hyperplasia, adrenal carcinoma, adrenal adenoma, and pituitary ACTH hypersecretion. Remember, the most common cause of the Conn syndrome is adrenal adenoma, right? That is the most common cause of Conn syndrome. Now you take this hyperaldosteronism, or it is of two types. One is your primary hyperaldosteronism and the other one is secondary hyperaldosteronism. Now let me discuss what are the etiologies which will cause primary, what are the etiologies which will cause secondary. But first of all, you should know the differences between primary hyperaldosteronism and secondary hyperaldosteronism. Let me discuss that, and later on I will discuss the etiology of primary and as well as the secondary. Now if you take the word primary hyperaldosteronism, so in primary hyperaldosteronism, please remember the pathology is directly within the gland, right? The pathology is directly within the gland. Now what is that pathology directly within the gland? That includes adrenal adenoma and the other one is bilateral adrenal hyperplasia. Right? The other one is bilateral adrenal hyperplasia. These are the causes for primary hyperaldosteronism. That means the pathology is directly within the gland. Now, one important point you should remember is that we use the word Conn syndrome. Right? We use the word Conn syndrome only for adrenal adenoma. Right? We don't use the word Conn syndrome for bilateral adrenal hyperplasia. No. We use the word Conn syndrome only for adrenal adenoma. Now, you should know one important point here. If the question is asked what is the most common cause of Conn syndrome, then the answer is adrenal adenoma. But if the question is asked what is the most common cause of primary hyperaldosteronism, right? If the question is asked what is the most common cause of primary hyperaldosteronism, then the answer is bilateral adrenal hyperplasia. Right? Then the answer is bilateral adrenal hyperplasia. Now you should know what is the secondary hyperaldosteronism. So if you take this secondary hyperaldosteronism is a condition due to decrease in the blood pressure of the individual of any reason. Whenever there is decrease in blood pressure of the individual, what will happen? There will be activation of the RAS mechanism. And once there is activation of RAS mechanism, there will be excessive production of the aldosterone. Right? There will be excessive production of the aldosterone. That is what is your secondary hyperaldosteronism. So in secondary hyperaldosteronism, the pathology is not directly in the gland. Right? The pathology is not directly in the gland. In secondary hyperaldosteronism, it is the systemic causes. Now, what are those systemic causes? Let me tell you that. The most common cause of secondary hyperaldosteronism is congestive heart failure. That is the most common cause for secondary hyperaldosteronism. And the other important cause for secondary hyperaldosteronism is cirrhosis of liver. Right, cirrhosis of liver. These two are the most common causes for the secondary hyperaldosteronism. Now, let me just tell you what are the other etiologies of primary. See, primary already I have said you, adrenal adenoma and bilateral adrenal hyperplasia. And apart from that, we have many other conditions also. Like you see here, adrenal adenoma, which is nothing but Conn Syndrome. It constitutes 40% of causes for primary hyperaldosteronism. And you take bilateral adrenal hyperplasia, that constitutes 60% causes for the primary hyperaldosteronism. Actually, the most common cause for primary hyperaldosteronism is bilateral adrenal hyperplasia. Right? It is your bilateral adrenal hyperplasia. But the most common cause for Conn syndrome is your adrenal adenoma. Okay. Now, apart from that, we also have some rare causes of the primary hyperaldosteronism. Now, what are those rare causes? Let me tell you. The rare causes include, number one, syndrome of apparent mineralocorticoid excess. Number two, Cushing syndrome can also cause hyperaldosteronism. Glucocorticoid resistance, adrenocortical carcinoma, congenital adrenal hyperplasia, progesterone-induced hypertension, and the Liddle syndrome. So, these are the other rare causes for the primary hyperaldosteronism. But the most common cause, as already I have said you for the Conn syndrome, it is your adrenal adenoma. And most common cause for primary hyperaldosteronism, that is bilateral adrenal hyperplasia. Now, I have taught you what do you mean by the word primary and what do you mean by the word secondary, we have discussed. But you should know what is the difference in the parameters in between primary and as well as secondary. In primary, what did I tell you? The pathology is directly within the gland. Right? The pathology is directly within the gland in case of the primary hyperaldosteronism. So when pathology is directly within the gland, what will happen to your aldosterone levels? The aldosterone levels, it increases. Right? Aldosterone level increases. When aldosterone level increases, what will happen to your sodium and water retention? Sodium and water retention increases. When sodium and water retention increases, what will happen to your renal perfusion? Renal perfusion also, it increases. So thereby, what will happen to your renin levels? There will be decrease in the renin levels. So what I want to tell you now, primary hyperaldosteronism, that is Conn syndrome, is a low renin hypertension. You will have a decreased renin in primary hyperaldosteronism. Whereas, you take in case of the secondary hyperaldosteronism. Secondary hyperaldosteronism is due to decrease in the volume of the fluid. Right? It is due to decrease in the volume of the fluid. Okay? That is, the blood pressure of the individual will be reduced here. Right? The blood pressure of the individual will be reduced here. When the blood pressure of the individual is reduced, there will be decrease in the GFR. And once there is decrease in GFR, there will be activation of the RAS mechanism. Right? There will be activation of the RAS mechanism. Now, because of the activation of RAS, there will be increase in the renin levels. Right? There will be increase in the renin levels. So now what I want to tell you is, in primary hyperaldosteronism, there will be decrease in the renin, and in secondary hyperaldosteronism, there will be increase in the renin. So this is a very, very important difference between the primary and as well as the secondary hyperaldosteronism. Okay. Now, after having discussed about the differences between primary and secondary, and after having discussed about the etiology of primary and secondary, let me explain you the clinical manifestations in patients with the primary hyperaldosteronism. For that, let me just show you a question. So, the question is, which of the following is not a feature of the primary hyperaldosteronism? The options are pedal edema, diastolic hypertension, polyuria, and then the hypokalemia. So, which of the following is not a feature of primary hyperaldosteronism? The answer is the pedal edema. Right? The answer is pedal edema. So, excess aldosterone does not produce edema. Right? So, you might be surprised. You might think that, sir, hyperaldosteronism, it will cause excessive sodium and water retention. And when it is causing excessive sodium and water retention, there should be pedal edema. But why there is no pedal edema? Let me explain you. Now, let me just start giving you the explanation of the clinical features of the Conn syndrome or the primary hyperaldosteronism. Okay. Now, the clinical features of increased aldosterone levels. So, if you take the clinical features of increased aldosterone levels, it could be due to increased sodium and water retention, because aldosterone will cause sodium and water retention, right? So, it could be due to increased sodium and water retention, right? Number 2, it could be due to, what does the aldosterone do to the potassium? It will cause excretion. So, there will be excessive potassium excretion. So, the individual can have hypokalemia, right? And the third thing is, the aldosterone will cause the H plus ion excretion, right? Aldosterone causes H plus ion excretion. So, that will result in decrease in H plus ions, that is alkalosis, right? That is alkalosis. So, the clinical features of the hyperaldosteronism is due to these three reasons: increased sodium and water retention, potassium excretion, and as well as the H plus ion excretion. Now, first we will take up the clinical features due to hypokalemia, then I will take up subsequently the remaining. Now, you take the clinical features due to hypokalemia. Remember, potassium, it is very much required for the action potential within a muscle. And if there is hypokalemia, the repolarization or your action potential within the muscle is grossly affected, and the individual will have very severe muscle weakness. Right? The individual will have very severe muscle weakness secondary to hypokalemia. And the other point is, hypokalemia, it will affect the heart very badly. So because of hypokalemia, the individual can develop ventricular arrhythmias. Right? The individual will develop ventricular arrhythmias secondary to your hypokalemia. Third, remember, potassium, it is very much required for the activity of the cells within the nephron. And if there is hypokalemia, the renal tubules cannot reabsorb the water, because action potentials within the renal tubular cells are not being maintained, and that is the reason why the renal tubular capacity for reabsorption of water will not be there. So, because of hypokalemia, the individual will have polyuria. Right? The individual will have polyuria. Okay. So, why polyuria? Because the renal tubular water reabsorption is not there. And that is the reason why the individual will have polyuria. And subsequent to polyuria, there will be also polydipsia. So, these will be the clinical manifestations secondary to your hypokalemia. Now, let me just subsequently tell you what will be the clinical manifestations because of increased sodium and as well as water retention. Because of increased sodium and water retention, let me tell you, the clinical features include the following. Number 1, there will be diastolic hypertension, right? Number 2, there is no edema, right? Number 2, there is no edema, and number 3, there will be polyuria. Now, I will explain you why there will be diastolic hypertension, why there is no edema, and why there is no polyuria. Why there is polyuria, I will explain you secondary to your increased sodium and as well as water retention. Now, so you see here, whenever there is increased sodium and water retention, secondary to hyperaldosteronism, there will be, right, there will be increased fluid volume in the body, right? There will be increased fluid volume within the body, and subsequently what will happen, there will be increase in the venous return, and once there is increase in the venous return, subsequently there will be also increase in the cardiac output of the individual. And as the cardiac output of the individual increases, there will be also increase in the blood pressure of the individual. As the blood pressure of the individual increases, there will be increase in the glomerular filtration rate. Right? There will be increase in the glomerular filtration rate. Now, as the glomerular filtration rate of the individual increases, please remember, there will be also increase in the urine output of the individual, and that will make the individual to develop what is called polyuria. Right? That will make the individual to develop what is called polyuria. So, because of this polyuria, there is no edema. Right? Because of this polyuria, there is no edema. Now, one important catch you should make out here is the GFR is increased, but at the level of distal convoluted tubule, aldosterone, right, at the level of distal convoluted tubule, aldosterone, it will cause sodium and water retention. Right, at the level of distal convoluted tubule, aldosterone will cause the sodium and as well as water retention. That point you have to remember here. That point you have to remember. In case of Conn syndrome, there is hyperaldosteronism. So there is increased sodium and water retention at the level of the distal convoluted tubule. Then why is this polyuria then? Now let me explain you for this. Okay. Actually this is the sequence. Polyuria will be there. In spite of increased aldosterone, there will be polyuria. Why? Let me explain you. Now for this, to understand, you should understand the concept in diabetes mellitus, and the same concept we can apply even in case of the hyperaldosteronism as well. So first, let me explain you in diabetes mellitus what will happen. In diabetes mellitus, you see here, this is the Bowman's capsule, right, which is continuing down as the tubule, right, which is continuing down as a tubule. Now, what will happen in a normal individual? The glucose, it will be filtered from glomerulus. The glucose will be filtered into the tubule, and the glucose that is filtered into the tubule, this glucose has to be reabsorbed from the proximal convoluted tubule. Right, this glucose has to be reabsorbed from the proximal convoluted tubule. The glucose has to be reabsorbed. That is what will happen in a normal individual. But in diabetes mellitus, what is happening? There is excessive glucose overload. Right, there is excessive glucose overload. So now the tubule says that I cannot handle this amount of glucose. So there will be a tubular maximum for glucose. There will be development of saturation of reabsorption of the glucose, and the remaining glucose, right? The remaining glucose, it will appear in the urine. Right? The remaining glucose will appear in the urine. So, in case of diabetes mellitus, because there is excessive filtration of the glucose from glomerulus into the Bowman's capsule into the tubule is not able to reabsorb that excess amount of glucose, and that excess glucose is getting excreted in the urine. And that is the reason why there is glucosuria. The same concept we will apply in your Conn syndrome now. So, in case of the Conn syndrome or primary hyperaldosteronism, what is happening? The excess amount of sodium and as well as water, that will be filtered into the Bowman's capsule from glomerulus. Now, this particular excess water will enter into the tubule. Normally, what should the tubule do? Normally, the tubule has to reabsorb the water. That should happen normally. But here what is happening? Because of increased aldosterone, there is increased sodium and water reabsorption, and there is increased glomerular filtration rate also. That means the tubule is receiving excess amount of water. Tubule is receiving excess amount of sodium. Now the tubule says, I cannot reabsorb this amount of sodium and water. So this excess sodium and as well as water, right, this excess sodium and as well as water, it will be excreted. Right, this excess sodium and as well as water, it gets excreted out in the urine. So this phenomenon is called as pressure diuresis and pressure natriuresis. Right, this phenomenon is called pressure diuresis and pressure natriuresis. Okay, so the tubule is under very high pressure of sodium and water, and thereby there is the pressure diuresis and as well as the pressure natriuresis. Now this phenomenon, right, this phenomenon is called aldosterone escape phenomenon. Right, this phenomenon is called aldosterone escape phenomenon. Okay, so aldosterone is unable to show its action. Aldosterone, it is not causing your sodium and water reabsorption, in spite the aldosterone is very high. Right, that is what is called as the aldosterone escape phenomenon. So because of this aldosterone escape phenomenon, the individual will not have the pedal edema. The individual will have polyuria. And I said you, the blood pressure of the individual increases, and that is nothing but your diastolic hypertension. So now let me just summarize the clinical features of primary hyperaldosteronism. Right, you see this table. So whenever there is increase in mineralocorticoids or aldosterone, there will be increase in sodium and water retention, due to which there will be diastolic hypertension. There is no edema. And there will be hypokalemia and hyperaldosteronism, due to which there will be ventricular arrhythmias, polyuria and polydipsia, muscle wasting and fatigue. And the H plus ion reabsorption does not occur. There will be excretion of H plus ion that will make the individual to develop what is called metabolic alkalosis. So this is about the clinical features of the primary hyperaldosteronism. Now let me just show you one question here, which is not the feature of primary hyperaldosteronism. Hypokalemia, hypertension, hypernatremia, increased renin levels. Remember, as already we have discussed, in primary hyperaldosteronism, they will not have increased renin. They will have decreased renin. Right? They will have decreased renin. The remaining all, hypotension will be there, hypertension will be there, and as well as hypernatremia also will be there. Now, there is one of the very important differential diagnosis of your Conn syndrome. The important differential diagnosis of the Conn syndrome is Liddle syndrome. Right? Differential diagnosis of Conn syndrome is Liddle syndrome. Liddle syndrome, it is a genetic disorder where you have autosomal dominant type of inheritance. And what is the defect? The defect is in epithelial sodium channels. Right? ENaC channels are nothing but epithelial sodium channels. And what will be the defect? The defect will be gain of function of the epithelial sodium channels. Gain of function of the epithelial sodium channels. Okay, so because of gain of function of epithelial sodium channels, there will be increased sodium and water retention. There will be potassium excretion resulting in hypokalemia, and there will be H+ ion excretion resulting in, right, there will be H+ ion excretion resulting in metabolic alkalosis. Okay, now what is the drug of choice for Liddle syndrome? Drug of choice for Liddle syndrome is, it is your epithelial sodium channel blocker. Right, it is your epithelial sodium channel blocker. And what is that epithelial sodium channel blocker? That is amiloride. Or triamterene. Right, amiloride or triamterene. So this is one of the very important differential diagnosis of the Conn syndrome, which is nothing but the Liddle syndrome. Now, after having discussed about this, let me explain you the investigations. Okay, right, you see another question. Excess aldosterone is associated with all of the following except hyperkalemia, hypokalemia, sodium retention, hypertension. Sodium retention will be there. Hypertension will also be there, that is diastolic hypertension. And this excess aldosterone is associated with the hypokalemia. But what is asked? Except. So hyperkalemia will not be there. Right? Hyperkalemia will not be there, but hypokalemia will be there. Okay. Now, let me discuss the investigations. Yes, you see another very, very important question. Prior to testing for hyperaldosteronism, patient ideally should hold all the medications. Right? Patients ideally should hold all the medications except diuretics, ACE inhibitors, NSAIDs, verapamil. Let me tell you, the individual has to hold on diuretics, ACE inhibitors, NSAIDs, but verapamil is not required. The question asked is except. So remember, almost like 2 weeks prior to testing, like what are the precautions you need to take if you want to check for the primary hyperaldosteronism? See, for at least 2 weeks prior to testing, patient should consume a diet which is high in sodium chloride. Now why? Because if he is consuming a diet which is rich in sodium chloride, the fluid volume increases and that will increase the GFR and that will decrease the aldosterone levels. That is what should happen normally. That is what should happen normally. But in spite of taking a diet which is rich in sodium chloride, if the aldosterone levels are still high, then we need to suspect primary hyperaldosteronism. Okay. And he also should hold on the other medications like diuretics. Like which diuretics? Aldosterone antagonist. They should be withheld. Because when you are giving aldosterone antagonist, that can suppress the aldosterone levels, which will give you a false value. And you take ACE inhibitors and as well as the angiotensin receptor blockers. ACE inhibitors and as well as angiotensin receptor blockers, please remember, both of these drugs, they will inhibit the RAS mechanism, right? Both of them, they will inhibit the RAS mechanism, and that is the reason why they will affect the aldosterone levels. And at the same time, beta blockers, clonidine, NSAIDs, oral estrogen, oral contraceptives, all of them, they should be stopped because they can affect the aldosterone levels. But which drugs are allowed? Calcium channel blockers like verapamil, arteriolar vasodilators like hydralazine, then terazosin and as well as the doxazosin, that is your alpha blockers. They can be permitted. They will not affect the levels of your aldosterone levels. So they can be given. But your beta blockers, ACE inhibitors, ARBs, NSAIDs, clonidine, OCPs, oral estrogens, all that have to be stopped. Now, coming to the laboratory anomalies. Remember, these individuals, they will have transient hypernatremia. Right, there will be transient hypernatremia. So, sodium levels will be increased only transiently. Again, they get normalized. Why? Because of your pressure natriuresis. We have discussed in aldosterone escape phenomenon. So, there will be only transient hypernatremia. Then, followed by that, there will be hypokalemia. Right? Why? Because aldosterone is causing potassium excretion. And secondary to this particular hypokalemia, what will the ECG changes show? ECG, it will show the T-wave inversions. ECG will show the appearance of the U wave. Right? Appearance of the U wave. That is what you will have in hypokalemia. Now, if you take the ABG, arterial blood gas analysis, this will show metabolic alkalosis. Right? This will show metabolic alkalosis. Okay. Next. Then, if you want to differentiate primary hyperaldosteronism from secondary hyperaldosteronism, remember, in primary hyperaldosteronism, renin levels are low. And in case of secondary hyperaldosteronism, renin levels, they are very high. This is how you have to differentiate primary and as well as secondary. And the other important investigation is the ultrasound of the abdomen. Ultrasound of the abdomen, it will show you bilateral adrenal enlargement. Right? For suppose, if there is like bilateral adrenal adenoma or bilateral adrenal hyperplasia, so there will be bilateral adrenal enlargement. Okay? And next thing is the CT scan of the abdomen. But CT scan of the abdomen has to be done only after confirming by the chemical analysis. So even CT scan of the abdomen, that will show you bilateral adrenal hyperplasia or bilateral adrenal tumors. Now, apart from these investigations, you take the aldosterone levels, right? Aldosterone renin ratio. So, aldosterone renin ratio. This is the ideal screening test for your hyperaldosteronism. What is the normal aldosterone renin ratio? Remember, what is the normal aldosterone renin ratio? Normal aldosterone renin ratio is 20. That is a normal aldosterone renin ratio. And if you take the normal aldosterone levels, normal aldosterone levels are less than 5 nanograms per deciliter. That is the normal aldosterone levels. Now, for suppose, when will you confirm or when will you suggest it is primary hyperaldosteronism? When ratio is more than 67, right? When ratio is greater than 67, this is highly suggestive of primary hyperaldosteronism. Right? This is very much suggestive of the primary hyperaldosteronism. And If the value, if it is in between 30 and 67, it is suspicious, right? It is suspicious of the hyperaldosteronism. And if the levels are in between 24 and 30, it is indeterminate. Right? And if the ratio is less than 24, this will exclude primary hyperaldosteronism. Okay, so what should be the level to call it as primary hyperaldosteronism? The value should be more than 67. Which one? The aldosterone-renin ratio, and that is the ideal screening test. And normal aldosterone levels, already I have said you, normal value is less than 5 nanograms per deciliter. And if the levels are in between 5 to 10, it is borderline. And if the levels of aldosterone, if it is more than 10 to 15 nanograms per deciliter, this is suggestive of the primary hyperaldosteronism. Okay. Now, these are the screening tests what we have discussed. Now, let me tell you what is the confirmatory test for your primary hyperaldosteronism. There are like 4 confirmatory tests, out of which is the investigation of choice I will discuss. So, these are the confirmatory tests. That is the fludrocortisone suppression test. Number 2, intravenous saline suppression test, oral salt loading test, captopril challenge test. Out of which the investigation of choice is the oral salt loading test. Now 2 points you should remember. The ideal screening test, aldosterone-renin ratio. If aldosterone-renin ratio is more than 67, it is highly suggestive of primary hyperaldosteronism. And the second thing is investigation of choice, that is oral salt loading test. That is the investigation of choice. Now let me just give you a small idea about the oral salt loading test. Now, if you are giving the oral salt to an individual, what will happen to the fluid volume? The fluid volume, it increases. Right? The fluid volume, it increases. When the fluid volume increases, what should happen to your RAS? The RAS has to be inhibited. Right? When the fluid volume increases, what should happen to your RAS? The RAS has to be inhibited. The RAS will get inhibited. And thereby, the aldosterone levels, it will become normal. Right? Thereby, the aldosterone levels, it will become normal. That is what will, that means it will be reduced. That is what should happen normally. Right? That is what should happen normally. But here what is happening? By giving the excess oral salt, in spite of giving the excess oral salt, the aldosterone levels are still high. Right? The aldosterone levels are still high. That is what is called as the oral salt loading test. Now let me give you the actual pictures. So oral sodium chloride, how much you have to give? 300 millimoles of sodium per day. For 3 days you have to give. Then you have to check for the urine aldosterone on the 3rd day. And if the urine aldosterone is more than 12 or more than 14 micrograms per 24 hours, then this will confirm the primary hyperaldosteronism. This is the actual test, right? So, investigation of choice is your oral salt loading test. Now, following that, imaging already I have discussed. So, all the confirmed patients, they have to undergo imaging. What is that? CT or MRI of the abdomen. Why? In order to look for the adrenal mass. And the other important thing is whether it is unilateral hyperaldosteronism or whether it is bilateral hyperaldosteronism, how will you differentiate? You have to do adrenal venous sampling. Right? You have to do adrenal venous sampling. Adrenal venous sampling is the gold standard test for differentiating unilateral from bilateral primary hyperaldosteronism. It's a gold standard test. Which one? The adrenal venous sampling. Now, followed by that, for example, if the individual or some patients having the features of hyperaldosteronism from young age, then they have to undergo the genetic testing. Genetic testing is recommended for patients with confirmed primary aldosteronism by the age of 20 years and those with a family history of primary hyperaldosteronism or an individual with stroke at young age under the age group of 40 years. For them, you need to do the genetic testing. Now, after having discussed about the investigations, let me discuss the treatment. So, treatment in case of the primary hyperaldosteronism is you need to give aldosterone antagonists. Right? And these particular aldosterone antagonists, we have spironolactone, so spironolactone, it will cause a painful gynecomastia, and the alternative to your spironolactone is the eplerenone. Right? Alternative to your aldosterone antagonist spironolactone is eplerenone. So this is about the medical management. So, but remember, medical management is not the treatment of choice. Medical management has to be given for bilateral adrenal adenomas. Right? For bilateral adrenal adenomas or bilateral adrenal hyperplasia, we give spironolactone or eplerenone. But for unilateral adrenal adenomas, right? Unilateral adrenal adenomas, surgical resection of the tumor right? Surgical resection of the tumor, it is the treatment of choice. Right? Surgical resection of the tumor is the treatment of choice for unilateral adrenal adenomas. So this completes the discussion of the Conn syndrome. Let me just show you some questions. Testing for primary aldosteronism should be done for all hypertensive patients except. Options are sustained hypertension above 150 by 100 millimeters of mercury on 3 different days. Second, hypertension resistant to 3 conventional antihypertensive drugs including a diuretic. Third option, controlled blood pressure requiring 4 or more antihypertensive drugs. Fourth option, hyperkalemia whether spontaneous or diuretic induced. The question asked is except. In which of the following you will not test for the primary hyperaldosteronism? The answer is D. Whenever there is hyperkalemia, you don't require to test for the primary hyperaldosteronism. Why? Because in primary hyperaldosteronism, you will have hypokalemia but not hyperkalemia. Right? So that's a very, very important point that you need to remember. Now, let me just tell you what are the indications for testing aldosterone in which clinical scenarios. I have a big list, I'll just show you. So these are all the conditions like sustained hypertension like above 150 by 100 on 3 different days. Like it is not that you have to check for only primary hyperaldosteronism. You have to test for all the secondary causes for hypertension. Okay. Next. Hypertension resistant to 3 conventional antihypertensive drugs including a diuretic. Resistant hypertension, you have to check for what is the underlying secondary hypertension. As a part of the workup, you need to test for even for the aldosterone levels also. Right? Next. Controlled blood pressure requiring 4 or more antihypertensive drugs. Hypokalemia, whether spontaneous or diuretic induced. Personal or family history of early onset hypertension. First degree relative with primary aldosteronism. Presence of an adrenal mass, low plasma renin activity. So in all these conditions, you have to test for primary hyperaldosteronism. You have to test for primary hyperaldosteronism. Okay, right. Now, I'll just show you one more question. It's a clinical question and then we will wind up this session. So I have a 32-year-old man presenting to the clinic as a new patient to establish the primary care. He has a 2-year history of hypertension which is managed with the calcium channel blockers. He has no knowledge of the cause of his hypertension. He is currently without complaints and only wants a refill on his medications. His physical examination is unremarkable, but laboratory results shows hypokalemia. Which of the following statements regarding hyperaldosteronism is true? First option, the most common cause of secondary hyperaldosteronism are congestive heart failure and cirrhosis with ascites. Second option, treatment of primary adrenal hyperaldosteronism is spironolactone. Third option, patients with primary adrenal hyperaldosteronism usually present with hypertension, hypokalemia and metabolic acidosis. Fourth option, diagnosis of primary adrenal hyperaldosteronism is confirmed by elevation in the levels of both renin and as well as aldosterone. So the question asked is, which is a true statement regarding the hyperaldosteronism? Remember, the most common cause for secondary hyperaldosteronism is congestive heart failure and cirrhosis of liver. Now, you take the other options. Treatment for primary hyperaldosteronism is spironolactone is a wrong statement. What did I tell you? For the primary hyperaldosteronism, the treatment of choice is surgical resection of the tumor. Right? Surgical resection of the tumor. And you take the third one. Patients with primary adrenal hyperaldosteronism usually present with hypertension, hypokalemia and metabolic acidosis. Remember, they don't present with metabolic acidosis. They present with metabolic alkalosis. Right? They present with metabolic alkalosis, not metabolic acidosis. Okay? Next, diagnosis of primary adrenal hyper is confirmed by elevation in the levels of both renin and aldosterone. Remember, in primary adrenal hyperaldosteronism, what did I tell you? Aldosterone levels will be high, but renin levels will be low. Right? Renin levels will be low. So, the correct answer to this question is the first option. That is the most common cause for secondary hyperaldosteronism is heart failure and cirrhosis of liver. So, with this, I conclude this important topic of the Conn Syndrome. So, what is that you have to understand the basic physiology of aldosterone you have to know. Then followed by that etiology, clinical features, investigations and treatment of the primary and as well as secondary hyperaldosteronism. Thank you very much.